Hello, everyone, and welcome to today's industry webinar, Enhanced Care with Telehealth, Behavioral Health Case Study and Lessons Learned During COVID-19. My name is Ellen Knowles. I am the Marketing Communications Manager here at Azalea Health, and I will serve as your moderator for today's presentation. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Everyone on this call is listening in using their computer audio system by default. If you would prefer to join over the phone, just select telephone and the audio pane on the right-hand side of your screen, and the dial-in information will be displayed there. You will have the opportunity to submit questions by typing into the questions pane of the control panel, and you may send in your questions at any time during the webinar. We will collect them and address during the Q&A session at the end of today's presentation. We also have a few poll questions throughout the webinar to help us get to know our audience a bit better. So please take a moment and answer as those appear. We have a great agenda for today's webinar. We will start with introducing our presenters, then dive into some survey results regarding telehealth in the time of COVID-19, some key regulatory changes, and we have an exciting real-life use case to share with you today from an Azalea Health customer, Mebs Couseling, as well as discussing telehealth in the hospital setting. And then finally, we will wrap up with our Q&A session at the end. I am now excited to introduce our presenters today. We have Anna Humes. Anna is a behavioral health therapist working with children, adults, and families. Her passion is assisting them to find balance, stability, and peace. She holds a Master's of Social Work from the University of Cincinnati and joined the Mebs Couseling agency in 2011, where she utilizes an array of approaches to help clients achieve their desired outcomes. Next, we have Dr. Avinesh Bhar. Dr. Avi is a board-certified pulmonary critical care and sleep medicine physician. He has been in practice for over 7 years following the completion of his fellowships at Washington University in St. Louis and the University of Tennessee, Memphis. He also holds an MBA from the University of Chicago. In 2016, he was inducted into the Asia 21 Young Leaders Initiative by the Asia Society. Next, we have Kaylee Berkeley. Kaylee has been with Azalea Health for over 7 years. In her current role as Director of Sales Engineering, she is able to work with both prospects and current clients to design workflows and best practices across both hospital and ambulatory product lines. Her team closely monitors trends and regulatory requirements in order to keep the company up to date to provide the best product and services. And last but not least, we have Jill Veah. Jill has over 20 years of experience in information technology and is currently the ITM project manager for Mebs Couseling. She's been with Mebs for 9 years and played a large role in transitioning Mebs to an electronic health record system. And recently, Jill assisted the agency in testing, implementing, and training providers on how to utilize telehealth. I want to thank all of you for being here today. And before I turn it over to Kaylee Berkeley to get us started, I'm going to go ahead and launch our first poll question, which asks, are you offering telehealth services to your patients and in which setting? Thank y'all for taking a moment to answer those. We've got some great responses coming in. And it looks like majority had started once COVID hit, and some did start before COVID. So thank you for responding to that poll. I will go ahead and close it and pass it over to you, Kaylee.
All right, thank you, Ellen. So like Ellen mentioned, to better understand the impact of the regulatory changes, restrictions on movement approaches to minimizing COVID exposure, Azalea surveyed more than 800 providers in mid-March, and we're looking at major functional areas impacted, operational areas were impacted, and then which areas these providers are prioritizing in response to the pandemic. So the responses were segmented across ambulatory, inpatient, and RHC. So we're going to start by going through some of those results. So starting with the functional impact, again, like I mentioned a second ago, these were conducted the week of March 11th, so it was the very beginning of the pandemic. The providers were asked to rank order the functional areas most impacted. Of those who responded, 44% identified patient engagement and utilization being the greatest impact, followed by clinical delivery, cited at 29% of respondents, and then last but not least, identified practice management and RCM as being impacted the most. Next slide, Ellen. Next, we're looking at the operational impacts. So again, providers were asked to list the top 3. These were administered as open questions though, so after a qualitative analysis of the responses identified, the top ones were going to be the lower patient volumes identified with the highest frequency as an operational impact, followed by the changes to workflow and no impact / limited impact. Again, the study was conducted early and our main clients weren't as impacted as they are now due to the fact that the majority of the Azalea client base is more rural and most of the COVID cases at the beginning of the study were coastal and within large cities. We know that some of these may have changed at this point. Last but not least, we're going to be looking at priorities. So again, providers were asked to identify the top 3 areas of prioritization in response to the pandemic, and these included 7 categories, and across all segments, telehealth and communication were the top priorities, followed by screening. Next slide. And to summarize the findings, COVID-19 has created a massive shift in the way providers deliver care, drive outreach, and maintain revenues. As hospitals and ambulatory clinics work to address lower patient volumes, staff shortages, and shift clinical delivery, patients, especially those that are older and have comorbidities, still require preventative care to lower risk of both COVID-19 and the avoidable ED visit. So the confluence of these shifts have resulted in the massive systemic adoption of telehealth across care settings and specialties, and the regulatory changes that open the door to telehealth are really long overdue. And it's likely that these changes, or at least a lot of them, are here to stay. So as a leading regulatory specialist said in a recent industry call, the cow is out of the barn and it isn't going back in. Next slide. Did you have another poll question here, Ellen?
Yes, I'm going to go ahead and launch our second poll question. If you can answer, how are you keeping up with the regulatory changes? Take a moment to respond to that, and we will look at some of the key takeaways. All right, thank you all for answering. It looks like a lot of you listen to webinars like ours, and then some have people in-house. So I'm going to go ahead and close this poll, and Kaylee can talk through some of the key takeaways.
Awesome, thank you, Ellen. So yeah, we'll talk just high level about some of the key changes in regulatory. We know you guys have a lot of options out there right now, so just want to keep you very informed. So let's take a look at what's changed. So one of the things that's changed is going to be the location. So now patients can be seen in their homes. So that's really waiving the originating site requirement that was in place before. Next, billing. So encounters are billed as if they were in person. So the place of service is updated, based on the type of visit. And then last but not least, technology. So we know right now that penalties are being waived for the use of non-HIPAA compliant technologies like FaceTime or Zoom, things like that. However, we're hearing a lot of concerns, around what happens, when this is over, or is there going to be backlash, things like that. So, it is really important to make sure that you are using a HIPAA compliant software such as Azalea or any other HIPAA compliant software, just to make sure that you're being covered at any point. Next slide. Those more regulatory key takeaways, CMS released the COVID-19 emergency declaration waivers for healthcare providers, and within that you have your licensing restrictions. That out-of-state practitioners can be licensed in the state where they are providing services when they are licensed in another state. I know a lot of border states or border cities will have that issue. And then the duration and type has changed. So CMS is allowing for patient-initiated, brief check-ins via phone, which usually last, 5 to 10 minutes. They're also paying for telephone calls of between 5 and 30 minutes. They have not, however, agreed to cover psychotherapy or E&M services by telehealth only. So next slide here. And then so telehealth also doesn't have to be used only for that episode of care. There's many ways to continue to use this down the road. So it can be used across the continuum of care to deliver and enhance behavioral health services. So SAMHSA has identified examples of telehealth used across 6 domains of care that are illustrated in this table above. And then there's tools available to help support care at each step in the process, all the way from assessment to collaboration. And to illustrate this even further, next up we're going to be hearing from Mebs Couseling on their journey with telehealth.
So a little bit of background, Mebs Counseling began providing behavioral health services about 20 years ago. Our agency is comprised of more than 50 providers, which include behavioral health professionals, or BHPs, who provide clinical interventions in the home, school, community, as well as traditional outpatient services in the office. BHPs also perform diagnostic assessments, developmental, and psychological testing services. On our provider team, we also have targeted case managers who primarily operate in the community, assisting clients gain access to social, medical, educational, and financial aid resources for patients with a serious mental illness diagnosis. Our community support associates are a team working exclusively in the community to assist in meeting the social needs and promote independence of our clients. Next slide. Within our agency, we treat a variety of individuals that include adults, children, families, and couples, using an evidence-based wraparound model that can include a team member from each of our programs, a therapist and a case manager, for example. We serve primarily Northern Kentucky area, which includes urban, suburban, and rural communities. A large portion of our client base includes a vulnerable population, as they fall at or below the poverty line and face difficult socioeconomic barriers to access of care. These services are provided in the home, school, traditional office, outpatient, and in the community. Next slide.
So prior to the COVID-19 crisis, remote populations face barriers to behavioral health services and specialty care in general. With the use of technology now, as the stay-at-home orders are in place, now people are getting more and more used to technology to stay connected. But prior to that, you may have experienced some of your providers being resistant to technology within your own practice, and there may have also been concerns enabling patients to utilize and understand technology. Next slide. So in our agency, we have actually been using Azalea Health as our EHR solution for about 6 years and had already started looking into telehealth prior to COVID. We actually did a telehealth demo with Azalea about 2 months prior to the pandemic. And then fortunately for us, Azalea announced their telehealth solution would be free to all customers during this crisis, which allowed us to have a secure HIPAA compliant system operational within about 24 hours of the COVID-19 national announcement. Next slide.
Providers understood that we needed a secure way to continue valuable and important services without extensive delays. So essentially, we had to build the plane while in flight. This required some legwork to ensure all providers would be able to provide the service, which meant becoming competent in the emergency regulatory changes following the guidelines at both the national and state level for service provision. New challenges also included assisting patients or caregivers to become adapted to this new normal. We found sometimes patients really struggled with the concept of social distancing, and there were some growing pains. Sometimes we had to rebuild rapport at a very basic level to maintain engagement. We also needed to set the expectation that an appointment time on telehealth has the same expectations as traditional face-to-face appointments. What worked also to drive patient adaptation was presenting telehealth as another way to visit your provider in a manner that seemed less uncertain than everything else going on. Acknowledging and validating patient concerns with utilization of telehealth. With more resistant patients, that narrative sounded like some people like it, some don't. How do you feel about trying a session online to see how it goes? After that, we will know if it's right for you. Next.
So, as with any new process, there's always fear and skepticism, and this was no different. However, as social distancing demanded remote patient care options, our providers and patients started to see the benefits of the telehealth approach. So we did our best as an agency to be as available as possible to our providers and provide them and our patients with as much information as we could on how to utilize a telehealth solution. Our providers primarily use iPads or computers to connect, but when we were testing it, we demoed the solution on all platforms. We did computers, laptops, tablets, Apple and Android devices, Chromebooks, everything we could think of to make sure that it would work no matter how the provider and client had to connect to each other. Luckily, it all worked. We offered daily training classes for our providers to learn the telehealth platform. We dedicated an open hour each day for providers to jump in and ask questions and work through any hiccups. And by the fourth day, those open hour training sessions were no longer needed. Our providers and our patients were off to the races with telehealth. Next slide.
During a typical session, which lasts about 60 to 90 minutes, we are able to provide intensive therapeutic interventions. Kids can be technology driven and have adapted really well to seeing their provider on camera. They were kind of bored into this life of technology, so it seems really natural. Kids get a kick out of showing their surroundings, their rooms, their favorite toys. Personally, I've noticed some patients who really struggled to make eye contact in traditional face-to-face have really responded positively to telehealth. I'm seeing them utilize the chat feature that's available to communicate things during sessions that may be hard to say, which has worked wonders for positive rapport building. This was a great unintended outcome from the rollout of the telehealth program. Next slide. Parents were given new insight into the care provided. In-school services do not typically allow for frequent check-ins following every session. With the use of this telehealth, we found parents being accessible to provide increased feedback and recommendations too. This was appreciated. Guardians have communicated that they are grateful we are able to continue treatment during this time without any interruption to services. I was also able to build such a positive rapport with some new clients of mine that the guardians sought services via telehealth at our agency, and they cited the flexibility and the convenience. Next slide.
We did see a slight decline in patient encounters for the first couple of weeks of the COVID-19 crisis. However, we had over 700 patient encounters for psychotherapy alone in the third week of providing services via telehealth. At this point, we're now averaging about 10 to 15 telehealth encounters per provider per day for psychotherapy alone. And we were able to increase our encounters by over 100 in just 1 week as patients and providers started to become more comfortable with telehealth. Next slide. So some of our suggestions and lessons that we've learned on how to successfully transition to telehealth would be to identify a clinical sponsor within your practice to collaborate with your technical support team to make sure both areas are being met effectively, and having that clinical person available to assist your providers on how to effectively provide the same type of service via telehealth as they would in person. Keep in mind that training is not a one and done effort. People are generally learners by doing. So remember that even though you actually trained people, once they start providing the service and engaging, questions are going to arise. So be available for those technical and clinical questions. And keeping in mind that patients are also on an adoption curve. So you have to be patient with them as they transition to this new way of treatment. And then also understanding that you have to make adjustments quickly. As we all know, regulations change very fast, and you have to move towards standardization of telehealth within your practice.
Thank you all, and we're going to pass it over to Dr. Avi. And before we do so, I'm going to have a quick poll question to launch here. If you can take a moment to answer that. If you are using telehealth, let us know in which setting is that being leveraged. Take a moment to answer. Looks like a lot of our audience is a majority outpatient, and we do have some that is a combination of inpatient and outpatient. Give a few more seconds here to get some answers in. All right, thank y'all for answering. I'll go ahead and close this poll, and Dr. Avi, you can take it away from here.
All right, thank you very much. Good afternoon, folks. So a little bit more about my background. I currently run a telemedicine practice for sleep and pulmonary medicine, and I'm actively in conversations with different hospitals, advising them on integrating telehealth into not only their outpatient practices, but also the inpatient practices. And how I got involved in this is I'm based in Georgia, and I live in Macon, and had come across many ICU transfers and many patients that would come and see me even in an outpatient setting from really long distances. And so that's how I got to know the geography of Georgia, actually through all the towns that patients would come from and all the smaller hospitals they get transferred out of. A background about Georgia, of course, you know, there's we've suffered probably one of the hardest hits in terms of rural healthcare, the closures of smaller hospitals, both critical access hospitals and public hospitals as well in smaller settings. Rural hospitals make up a large chunk out of the estimated 5,000 hospitals nationwide, so a big portion of that. The difference is, of course, if you have a hospital in a city, you can be usually, you know, if one closes, you can switch directions and move to a seek care in another hospital. In community settings, in smaller hospitals, smaller rural community settings, patients don't have these options. So that's why, you know, critical access hospital is truly critical. The idea is to try to figure out a way that care can be delivered by maintaining the level of standards of care without having to pay to have specialists nearby and so on. And that's how leveraging telehealth helps both in the inpatient and outpatient setting. Next slide. Now, what I find is, and what I've observed as well, is that a lot of hospitals end up being in this continuous game or chasing their tails on recruitment and retention. And it's something that, you know, if history tends to repeat itself, it's something that I think hospitals need to get out of, or at least change the way they look at recruiting their workforce. You know, convincing someone to move to a rural setting is going to be, obviously dependent on the individual themselves, but retaining them as well is another issue. You obviously have issues related to the spouse not finding the right kind of work, or whether they have adequate support in terms of other specialties. No clinician or no provider likes to work in an environment where they feel like they cannot practice at the top of their licensure, meaning that they want to care for patients and they don't like saying, I can't do this, or I can't tell you this, or I don't know what is going to happen because I don't have those resources available. And that's how telehealth actually helps with that significantly. It provides a scaffolding for you to build your practice on. It's easy to convince someone to come in or move to a smaller setting where they may be the only physical doctor in town with that specialty, when they know that they actually have the backing of a telehealth provider or a service for weekends and nights and times that they need to take a break, but also to bounce ideas off and to get a better understanding of how to manage their patients. So I think telehealth for workforce shortages needs to be, as opposed to a silver or the icing on top of a practice. I think we need to look at telehealth as the backbone or the scaffolding, and then build a workforce on top of that, because then you actually have a much more reliable workforce that's willing to work with you and come into work and take up residence in a small setting, knowing that they have the support. Funding and access has also been a perennial problem. I think with the CARES Act, the CARES Act that was passed recently, there's been a lot more funding available for telehealth resources as well. And I suggest, based on your location and so on, I think most of you all should have access to that. I think start looking at how to build telehealth capabilities, not only in the outpatient setting, but to start considering having that for the inpatient setting, because I think in smaller communities, it is important that we have a vibrant or robust hospitals, the hospital that is able to provide basic emergency care and specialty care that will then support the outpatient setting as well. When you end up transferring patients to larger hospitals or bigger cities, they end up also getting a lot of their care there. And while that may work for certain specialties or high-end specialties that you really cannot find a consultant for, I think a lot of care can be delivered closer to home if we have the right combination of inpatient, outpatient, and telehealth supporting that. So funding and access, I think, will get better. Next slide. So I've briefly touched on a lot of these points separately, but one of the main things is to get patients access to care. Whether it is a sleep practitioner or whether it's an OBGYN high-risk OB appointment. For example, virtual care, at least through COVID-19, has realigned or changed how we looked at things. Telehealth used to be, or even 6 months ago, was always an added feature that if you had it, okay, fine, great. If you didn't have it, business as usual. But I think it has opened patients' eyes to being able to connect to people at greater distances, but with the specialty they need, to be able to see a consultant without having to drive long distances as well. As rural communities age, getting transportation is also an issue. I find it bad that as a sleep and pulmonary practitioner, most of my patients who used to come and see me in my traditional practice, I used to be the fourth or fifth specialist that they would have to see, apart from their cardiologist, their primary care doctor, and endocrinologist, and so on. So in terms of getting access to care, I think this is huge. This allows patients to stay closer to home, get emergency care and hospital care close to where they live, but also be able to remain close to home when they do need to seek follow-up care. Treatments as well can be decided upon rather than having patients being discharged to follow up with a specialist at a larger hospital. A lot of decisions can be made, so you actually end up having patients who are a lot more satisfied with the quality of care they've received closer to home, because now they have answers, they have a treatment pathway, they have a plan in place, as opposed to a whole bunch of discharge paperwork going, see this doctor at this location, see this doctor at that location, see this other specialist here. And I think having that access to treatment or a treatment plan is huge for patient care. And I think where telehealth really closes the gap is in stronger patient engagement. Where healthcare really has lacked is its ability to engage consumers at a level that most consumers are already accustomed to. So we're not doing anything groundbreaking. We're just bringing consumer-based care closer to healthcare and allowing patients to engage specialists, engage the care they need from the comfort of their own home or even from their phone or devices at home. And you want to maintain the delivery within the community. If you end up transferring a patient because of inadequate access to specialists, for example, there is a loss of revenue, and this affects the smaller rural hospitals. When you transfer a patient out as well, they may not get rehab and further care closer to home, and you end up sacrificing the vital support that family has when they're closer to the patient. Also, along with all the other downstream revenues that hospitals can gain from more complex care requiring CT scans and rehab and long-term stay or even swing beds. And I think that's where we need to look at telehealth as a way to serve our patients, serve our community, and to keep our hospitals open in smaller rural settings. Capacity management is definitely one of them. I think from my own experiences, having patients through telemedicine cuts down the time taken over to turn over a room, for example. And so you can end up seeing a patient that you have in the office at the same time, then switch over to telemedicine appointment while you wait for that room to be clean and while you wait for a patient to get checked in. And so that capacity management, I think, is useful. But then you can also triage patients to decide who needs to come in and who can stay home. So I think in that sense, you also reduce some of your no-show rates, and it improves clinic and outpatient efficiency. So overall, that's, I think that kind of gives you a broad stroke of where telehealth or how telehealth should be looked at. I think it used to be a feature. I think it's becoming a necessity now, and I'm hoping from what Seema Verma, the CMS administrator, said, apart from all the changes that they made during this COVID situation, the telehealth will likely be the one that remains standing. And I think that's very encouraging for all of us to know that at least from a payer perspective and from a government perspective as well, there is a lot more push now to transition to telehealth as an initial point of contact, as opposed to a feature of how care is delivered. Thank you for now, and I'll just stop right there. And if there's any questions y'all have.
Thank you so much, Dr. Bhar. We will begin our Q&A session in just a moment. I'm going to go ahead and launch our final poll today. If you would like someone to follow up with you after today's webinar from Azalea Health, we can provide some more information regarding our telehealth solution and any additional questions you have. So take a moment to answer that, and then we will begin our Q&A session. As a reminder, you can still submit questions in the attendee control panel. All right. So our first question asks, you talked about having to rebuild reports as part of the rollout of telehealth. How did you do that? And that sounds like it is a question for Mebs.
And the question is,
what
exactly?
You talked about having to rebuild rapport as part of the rollout of telehealth. Rebuilding rapport with your patients via, through the telehealth solution versus in person. So what were some ways you did that?
So when I said rebuilding rapport, my clients weren't used to seeing me on camera. So getting used to seeing me in that light was when I talked about the basic rapport at a basic level, just that. We played games. I brought out my therapeutic questions, get to know me questions again, had them show me their surroundings, their favorite toys. If I haven't been in their home, I hadn't seen their places. So that was really interesting. So when I said rebuild rapport, those kind of activities.
Good, awesome. Thank you for answering that. Our next question asks, You mentioned that you provide intensive therapy through telehealth. Can you provide more details on what kind of therapy you are providing and how you've had to change what you would do face-to-face to accommodate telehealth?
So intensive therapy, utilizing trauma-focused CBT, for example, using the workbook materials. I sent those to my clients. I had them have them read. The parents have the materials ready for when session began, and we worked together through that. I've been also able to engage them in mindfulness techniques, just as I would in traditional face-to-face.
Okay, thank you for answering that one. We have a couple more for Mebs specifically. Are you as therapists challenged with a lack of nonverbal communication during telehealth visits? And if so, how do you address that gap?
I haven't noticed a lack of nonverbal. When I mentioned using the chat feature, it was more for kiddos and adults alike who weren't comfortable saying things out loud, like they were hard to say. So they used that to type it, and we processed from there. But I haven't had anyone like not refuse to engage and talking to me on it. Some people if they're using their phone, they'll set the phone down and like talk to me as if I'm in the room and not want to be on camera, but no one has refused to be verbal on the platform.
Great. Next question, also applying to you. We are having trouble with one of our therapists using telemedicine because they feel it's too impersonal. Do you have any advice on reassuring them?
I don't know about that one, honestly. I haven't found that it's impersonal. I do think that it's a case by case. Obviously it's not appropriate for every single client, but it is very personal. It's very one-on-one. You're in each of your private area and spaces, so you can absolutely do a whole lot with it.
All right, and then next question here is, for children, it's hard to sustain their attention during telehealth sessions at times. Are there specific therapeutic games that you would recommend?
Absolutely. Anything that's going to get your kiddos out of their seat, just as you would in traditional face-to-face. I like some of my kiddos with ADHD need to be up and moving, so we incorporate movement in our sessions. I've gone on a scavenger hunt, a nature scavenger hunt, and went with them with their device to look for things in nature. I have some mindfulness activities where we stand up and do some breathing and some body movement stuff. I am able to talk them through guided meditation. It's absolutely limitless.
Mm-hmm. Awesome. Okay, so a lot of options there. That's great. Our next question is for Dr. Bhar. How is medication administration handled with telemedicine during COVID-19, for example, with injections?
So you're referring to inpatient or outpatient?
For inpatient.
There isn't actually any issue because a lot of the telemedicine or telehealth is done via the EMR as well. So I mean, if for example, a ready-made solution where you have the or the video conferencing via the EMR itself, the physician will end up then accessing the EMR and putting orders in for whatever needs to be administered. And so the only issue ends up being is if they need medications that are, the only thing that telemedicine restricts on is providing or writing prescriptions for controlled substances. And that's the only major issue that we have when it comes to providing care. But obviously, if the patient needs a steroid shot, I write them a prescription. They end up taking that to their local pharmacy, or they end up taking it to their local urgent care to get that steroid shot. So I've done that with a lot of patients. So from an outpatient perspective, you may need to do some groundwork in terms of either accessing their pharmacy electronically and sending an order in, or sending an order in via a prescription or fax over to their primary care provider to get the certain medications given by IV. But for an inpatient setting, it's even easier.
Mm-hmm. Okay, great. Thank you for answering that. We have another question for you. How do you see wearables integrating into telehealth workflows and remote patient care?
So there are many these application platforms or APIs that allow you to interface with their Fitbits and so on. At this time, it depends on the telehealth provider that you have and how able they are to integrate that so the reports can be sent to you. Alternatively, I have patients who will snap a picture of whatever their report shows and email it to me. And so then I end up just looking at that kind of when during our sessions and so on, I'll refer to that. So I think that's a simple way to avoid the necessary technology having the technology have to adapt to what you have and which EMR system you have, is to have patients just snap a picture of a report and I'll bring that up to you when they speak to you. So I've had patients do that all the time. There are all these apps out there for, like, for example, sleep diaries. And so they will just take a snapshot of that and send me what it looks like, and I'll be able to refer to that when I have a consultation with them.
Great, thank you. We have a question for Kaylee. Any idea when we would need to go back to being strict with the HIPAA compliant software and locations?
Honestly, Ellen, at this time, we just don't know when they're going to be strict with that again. You've really just got to follow CMS very closely, but I don't think that it's something that anyone should take a chance of. We've heard, in recent weeks that, different platforms have been hacked and things like that. So adopting a HIPAA compliant software like an Azalea Health, like some of the other ones out there, it's just a best practice to go ahead and adopt as soon as possible. Because like
Awesome.
we mentioned earlier too, telehealth most likely isn't going away even after the pandemic is more in line.
Mm-hmm. Yep. Just waiting for different updates throughout this. Thank you, Kaylee. So for the group, we have a question. What do you feel are the primary drivers of clinician resistance to telehealth adoption? How is the difference between ambulatory and inpatient settings? So if a few of you want to take a moment to respond to that.
I can jump in there. So, going back to that question regarding a therapist who's not open to or doesn't think it's right, and I think the response is appropriate. I mean, there are some patients who need inpatient or an in-person an evaluation. I think the resistance mainly is more a personal belief. I still have physicians who say, "Oh, how do you end up examining the patient?" But if I were to record any of these clinicians actually interacting with the patient and examining them, about 90% of the time would be spent on the EMR along with the history taking, looking through their labs and looking through everything else. Less than 5% is actually done with stethoscope on or physical examination. So I think we end up being more dogmatic about how telehealth affects care rather than actually being pragmatic about it. So I think the COVID-19, I think there's a silver lining in all of this, is actually pushed patients to demand this more as well, and actually opened up clinicians' eyes to actually and forcing them to actually use it and going, okay, maybe there isn't a big difference. And so I think that would be the first way I would say, I think that's where the resistance mainly is. I don't think there's any true major practical hurdle except for more of psychological. What is the second question? Sorry.
How do you think the difference between ambulatory and inpatient settings are for those clinicians and the resistance?
I think from what I gather, the inpatient setting is usually a lot more pressing, meaning that, if you need a cardiology evaluation, if there is backing from administration to engage in telehealth, I think that allows physicians to then request for these, as opposed to then just making the request to transfer the patient out to a higher level of care. So I think if there's leadership buy-in to telehealth, I think from an inpatient perspective, it's a lot easier. While for outpatients, if you end up dealing with a situation which is not urgent or emergent, hence you can say, well, there's a specialist 45 minutes away from here. Let me go ahead and set you up to referral to see him in a few weeks. So it depends on the level of urgency. So a lot of outpatients is generally less urgent, and might be able to source a specialist that's within somewhat of a driving distance. I mean, 45 minutes an hour is still a long driving distance, and consider that it's both ways and the customary 45-minute wait in the waiting room before anyone sees you. You add to that, it's a whole afternoon done with. So I think from an inpatient perspective, there is a lot more urgency to get the consult in to see the patient and make a disposition about what needs to be done. And while an outpatient setting, I think there's a little bit more time that we can play with.
Great, thank you for answering that. We have one more question specifically for you, Dr. Bhar. From a clinical perspective, do you think primary care medicine foreseeably can be done completely online without ever seeing a patient in person? For example, elderly patients who are completely homebound.
I think the answer would have to be yes. There are some tools that they have right now that will allow you to examine a patient remotely as well. Tools that at some point in the near future, you could even have it where each home gets it, or if you sign up for an insurance product, you end up having a thermometer that's built in with a stethoscope or something where they can apply to their chest and so on. And so there's companies called MedWand or MEDWAND. I know they've been out of the market for a while, and you have all these tools that are there. I think it's a matter of getting that part of the workflow and understanding that these tools do exist. So to answer your question, yes, I think at some point near future, we should be able to conduct most of our care remotely, and then have patients come in specifically for either surgical procedures or anything that requires a procedure. And I'm hoping that for the sake of patients' convenience and also patients' ability to get the right specialist, because you have no idea when many patients have come to me and I see them struggling with their pulmonary issue and sleep issue, and it's usually a primary care that's left many years dealing with this on their own and trying their best, but not having the access to specialists. And finally a patient comes to me after many years, and I realized that it would have been simple enough that this conversation could have taken place online and their problems could have been solved years ago, as opposed to struggling. So I definitely think the future will be tele, and I think we as healthcare providers need to do tele first, or tele as the main structure, and then build our practices around that.
Awesome, thank you for answering that. We have another question for Mebs Counseling. How do you deal with technical challenges like poor connectivity on the side of the patient?
Well, unfortunately, those are things that we kind of can't control. So we just try and do our best. We try to have each provider and each of their clients, they try to have alternative ways to connect if there's some kind of an issue with an app or, something along those lines. We try to make sure that, people are connected to Wi-Fi if they're in an area that doesn't have great cell service, or if they need to maybe go to a space that maybe is, outside, if they are able to have better service out there, try and make sure that they're not in a basement or away from their internet connection as much as possible. So we just, those are kind of things that you have to be a little bit creative about, but trying to have alternative methods to communicate for each of your clients is definitely something that we would recommend.
Great, thank you for taking that. We have another question here for Kaylee. Do you think reimbursement for telehealth by payers will continue to increase after COVID-19 is over?
We can't speculate on the increases per se, but I know the demand for telehealth is going to be out there. Patients are getting used to be able to have follow-up visits, sick visits, things like that remotely, where they're not, we're all home right now, but not having to take as much time away for traveling to a doctor's office, things like that. So I think that increase is going to stay. So I would assume that, reimbursements will continue to grow as well.
And sorry to add in there as well, Georgia does have parity laws. So in terms of private payers have to match the in-person visit along with telehealth visit at the same level of reimbursement. I think where there might be growth is now with all these e-visit codes and so on, like 99421 to 99423, those e-visit codes along with telephone check-ins. So I think they're kind of dissecting that a little bit more. So it's not just a telehealth physician or a clinician visit, but also all these other support ways that we interact with patients that can get paid for as well.
Great. Thank you for taking that. We have a question for the group. How do you think workflows will change once social distancing restrictions have been lifted?
Sorry, can you repeat the question again? I didn't get that.
Yeah. How do you think workflows will change once the social distancing restrictions have been lifted? So I think once the different social distancing restrictions, depending per state and area, as those are being lifted, do you think that will continue to impact workflows?
I suspect it will for the short to medium term. There's been a lot of talk of whether we could get vaccines out and so on. And I think people will feel a little bit more protected once that happens. But I think as healthcare providers, we have to be acutely aware of our role in transmitting diseases to our patient population, as much as us getting infected from other patients as well. And so I think some of the practical steps that we've taken, which is may obviously with hand washing being a huge issue or a huge thing that's been pushed, along with wearing protective garments and so on. I mean, I don't think we have to don full PPEs and so on like we do right now in outpatient settings. And we're finding out as well that the disease isn't as isn't as fatal as we initially thought. So I think once we have a better understanding of all of this, I think our workflows should return to some form of normalcy, though I doubt it will go back to how we usually practiced in the past. So I think that has changed and will change. We'll put into place some of the mitigating measures that we have right now. We'll continue triaging patients and so on. But then also trying to see which patients don't need to come into the office and actually can be dealt with remotely as well. And so I think that's going to be some of the changes that we'll see in how our workflows will have, a larger number of patients that we deal with remotely to reduce the risk of us actually having to deal with patients coming in who may be sick. But on top of it, some of the workflows when they do come in will remain to protect us and protect our patient population.
And some things that patients and practices both can start to work on are, how can maybe patient portals, for example, be adopted more for patients to fill out a lot of that pre-visit paperwork instead of coming in and touching clipboards and pens and, adopting those other technologies that really eliminate some of the touching aspects.
Those are both really great points. Thank you. We have a question for the group as well. So do you know if there's a billing impact if a session needs to switch from video to audio? Is there any billing impact related to a telehealth session having to switch, during that same session from video to audio?
I mean, I can say we have not had that issue. You know, when the telehealth session begins, the telehealth session begins. We have not had an issue in regards to billing at this point. You know, it may arise as we get further into it, but at this point, we have not had any issues with that.
Okay, great.
So one of the benefits with Azalea's telehealth too here is that you can record those sessions even if they do become audio. And you can capture the information in the same way within the system. So you do have that extra documentation if somehow you do need to switch, you know, from that video to an audio. Everything can be documented, recorded, etc.
Great, thank you all for answering that. And then we are approaching our last question. I would love for each presenter to weigh in on this. What is the biggest takeaway that you've learned through COVID-19? So if each of you want to take a moment to share, Dr. Bhar, you could start. What's your biggest takeaway that you've learned through COVID-19?
I've always, had a biased view that healthcare as a whole is changes at a glacial pace. But I think what we've seen when we need to, we've hustled, we've adapted, so we can adapt. But more importantly, we must adapt for the sake of our patients.
Thank you. Let's see, Anna and Jill, do y'all have any takeaways you'd like to share?
That our clients are remarkably resilient through all of this, and the providers as well. We've really gotten together and come up with solutions to challenges during sessions, and even with working telehealth for the first time for a lot of folks.
From I'm not a clinician, but just from a person who works on operations side of things, I think it's important to connect with the people in your practice. We have weekly calls with our different teams that we have at Mebs, and we do them through video conferencing, and hair and makeup is not on most people, and none of us care. And it's good for, I think it's good for everybody to see other people's faces, and we talk about our struggles that we have personally, because as our patients are struggling with things, we are too. And I think that it's important to connect and admit that, and kind of sit with that a little bit, and help each other through some of those daily struggles. And seeing everybody on some kind of a video conference, it's the new way of communicating with our friends, families, and our coworkers, because we spend more time at work than we do anywhere else. And our coworkers, we're lucky enough at Mebs, our coworkers are like our family. And so being able to see each other is, I think, really essential to get through it, just like you would if you were in the office.
Thank you, Jill. And then last but not least, Kaylee, what are some takeaways that you've learned through COVID?
I'm just really proud to be part of a company that, we've always been customer service driven, but to really just on the drop of a dime to say, okay, we realize that there's an issue out here. We realize that our practices still need to be able to see their patients still need to go to the doctor. It wasn't even a decision. It was just like, telehealth is available to all of our clients right now. We're turning it on. They don't even have to talk to anybody. It wasn't a question. It was just really an amazing thing for me to see.
Yes, and I can vouch for that, because I know we've just worked hard to support our providers and all of our customers that are fighting this, and we're very thankful for them and very grateful. So I want to thank all of you. We are approaching the top of our time, so we will go ahead and conclude today's webinar. I do want to note that any questions submitted we did not have time to get to, we will address them following today's call. I want to thank all of our wonderful presenters today for sharing all of your insight. answering these questions. We really appreciate it. And a very special thanks to everyone for taking the time to attend today's webinar. As a reminder, today's slides will be shared in a follow-up email, and we'll also include a link to the recording in case you want to review again or share with any of your peers. On behalf of Azalea Health and our presenters, thank you for joining us and have a great rest of your day.